Continuing along, looking at anatomy with respect to movement as a central point of our network of meaning or of our semantic network, we're looking at hip extension. So our objectives, as is consistent, specific discussion of what hip extension is with respect to planes and axes, general discussion of the muscles that perform this action and the neurovascular bundle, as well as a general discussion of the areas to assess and treat should hip extension issues be suspected or reported. Once again, I've got that typed up a little funky, so please disregard that, but at least you get the idea of what we're aiming to do here. Our quick review of planes. The sagittal plane is a 50% cut of the body left to right. The horizontal or transverse plane is a 50% cut of the body top to bottom. The frontal plane or the coronal plane is a 50% cut of the body back to front. Axes are perpendicular to the plane. The sagittal plane has a horizontal or transverse axis. The horizontal or transverse plane has a vertical axis, and the frontal or coronal plane has an anterior to posterior or posterior to anterior axis, depending on the terminology you prefer. With respect to hip extension, it's going to occur in the sagittal plane about that relative horizontal or transverse axis. And with respect to the leg, so if we look at the bottom of my arm, so we pretend that that's the hip, it is going to be movement towards, well, that's not going to work all that well, but anyways, it's going to be movement towards the back of the body by the thigh. So the thigh is going to move posterior towards the back of the body in the sagittal plane about the horizontal or transverse axis, and that is hip extension. So multiple descriptions. So it's in the sagittal plane, it's about the horizontal or transverse axis, it is movement of the thigh towards the back of the body or the dorsum of the body. The muscles that are going to perform this, so again, as with hip flexion, you've got your big hitters, right? There are some muscles that are immediately considered hip extenders. However, we'll break it down a little bit more and add in the ones that are either considered primary or at least assistive. So you obviously have the gluteus maximus. You're going to add into that the posterior fibers of the gluteus minimus and medius, remembering that the anterior fibers of the gluteus minimus and medius are considered hip flexors. So in this case, the posterior fibers of gluteus minimus and gluteus medius are going to be aiding in hip extension. You have the ischiocondylar portion of the adductor magnus, or the hamstring portion, considered assistive at least with respect to hip extension. All of the hamstrings, so except for one, or one portion of one. So you have the semitendinosus is considered a hip extender. The semimembranosus is considered a hip extender. The long head of biceps femoris is considered a hip extender as it attaches to the ischial tuberosity, where the short head is from femur to, I believe, tibia. So the short head of the biceps femoris is not considered a hip extender, where the long head is. As well, the piriformis, under the right circumstances, is considered a hip extender. So it's not necessarily a simple hip extender, but under the right set of circumstances, it will aid in extension of the hip. As far as the neurovascular bundle is concerned, you're mostly, in the case of hip extension, going to be considering the lumbar column as well as the posterior surface of the gluteal region or the pelvis and the posterior surface of the thigh because of the neurovascular bundle. So it gets a little bit narrower than with hip extension. Hip extension, you've got to consider the lumbar column, the inguinal region, the anterior and medial surface of the thigh, as well as around the trochanter, generally speaking, because of the muscles that do this and the distribution of their neurovascular bundles. With respect to hip extension, this is slightly simpler. So the lumbar column, because a lot of the innervation is coming out of the lumbar plexus or the lumbosacral plexus. So you're going to have some mix of direct branches to muscles in the piriformis from the sacral plexus primarily. You're going to have the superior and inferior gluteal nerves. You're going to have the sciatic nerve. So those are your general neural regions, or the nerves that are going to supply this general motion. So you're going to have to consider the lumbar region and the posterior pelvic region with respect to that. You're talking about the superior and inferior gluteal arteries with respect to the gluteal muscles, as well as I can't remember exactly the artery to the piriformis, but you're going to be considering the region still, the posterior region. And then as far as the hamstrings are concerned, it is the profunda femoris artery. Now, that means, or at least with respect to the profunda femoris, because it is a branch, the perforating branches are going to be coming off of the femoral artery, you're going to have to now consider the anterior region, so the anterior soft tissues of the thigh, as well as the inguinal region. So that means that although you may be thinking about hip extension as your problem, if you're thinking about the vascular supply, you actually have to start to look to the front of the thigh, which again gives us the case that if we are behaving with respect to the motion dysfunctions found, we're going to be as accurate as we possibly can instead of chasing the neurovascular bundle. If you chase the neurovascular bundle, you'll miss what's right in front of you with respect to your actual tests or your actual assessments, which are going to be gross motion, identifying smaller motion problems, or yield to pressure of soft tissue. So when you squish soft tissue, it should squish evenly with its surroundings. When it doesn't, that is your positive finding, and you would treat in that area of comparatively higher tone, because if there's an area of the muscle adding pressure to a neurovascular bundle, it's likely going to be the one that has higher tone than its surroundings. So that said, you can chase the neurovascular bundle, or you can ideally pay attention to your motion tests, either in the form of larger motions of joints or in the form of yield to pressure from soft tissues. And then you will behave accurately to your findings as opposed to chasing the neurovascular bundles, expecting that just running the whole thing, as far as treatment is concerned, will give you the desired outcome. The desired outcome is more likely to be found in treating based on assessment findings in either large-scale motion, identifying smaller problems, or in relation to yield to soft or yield to pressure with respect to soft tissues. So again, the neurovascular bundle, you're considering the lumbar column, the posterior gluteal region, the hamstrings themselves, but as far as the vascular specifically, you have to at least consider the inguinal region and the anterior surface of the thigh with respect to the profunda femoris artery and where it's going to branch off of anyways. So as we've already noted in varying ways, the areas of consideration for assessment and treatment, the lumbar column, again, neurovascular bundle, the posterior soft tissues of the thigh, the muscles and the neurovascular bundle, the posterior region of the greater trochanter, but you do also have to, as far as the vascular portion of it, consider the inguinal region and the anterior thigh to some degree. Your general contraindications and red flags here: known fractures or tears, don't treat in that area. So in any of these areas that we've noted, a known fracture, a known tear, don't treat it because you can make it worse. So that's your red flag. A suspected fracture or tear, you refer out for differential diagnosis to a physician. If they identify no fracture or no tear, then there is some degree of safety to treat. You still want to be very cautious, but those are your general considerations there.